So I make it 9:30. Welcome everybody. I think we've got one or two people still to join us, and I think we've got a number of observers to the meeting today. Particular welcome to Lucy Upton, who's just joined us, colleague from CQC. So let's get underway. We have apologies from Lynette Wells, and Peter's deputising. We've not been notified of any new declarations of interest in advance of the meeting. So can we move to the minutes of the 13th of April? First of all, can I ask colleagues who were there, and thank you to Jackie for deputising for me while I recovered from surgery at that meeting. Are people content with the accuracy of the minutes? Vicky, is yours hand up?
Chair, just a tiny point at the bottom of page 4 in regard to the nursing fill rates. The additional capacity was required in November, December and January.
Okay, thank you. And Nikki?
Thanks, Chair. So I'm struggling just to get the paper in front of me, but it was on. Is there the paper here was about the nosocomials? Was that in the private?
That's part 2, I think.
Sorry.
Yeah.
Sorry.
Yeah. Okay. If there are no other questions on the minutes with that one amendment, we'll agree those as an accurate record. Thank you very much. There were no matters arising that specifically came up, unless colleagues have any matters arising that they want to raise themselves. I'll take silence as agreement. In which case, let's move to feedback from board committee chairs. For the finance committee, my note says that Damien is going to do the feedback this time. Is that right?
Sorry, yes, Steve.
Good.
Welcome. I was just getting off mute, which is the story of life, really. So the high-level points have been published. Just in summary, we reviewed the capital programme, particularly against last year and this year. We gave an update to the Building for Our Future strategic outline case, and we gave initial comments on how we're planning the productivity and efficiency update.
Okay, thank you. Any questions to Damien? On finance and planning, we, as the note says, we talked about the various transformation programs that will take place to underpin the BFF program. Because of the slightly unusual nature of the structure of this financial year, we talked about how the divisional plans on a page were being developed both for the first half year and then the second half year of this current financial year. We looked at the satisfactory month 1 summary position, looked at radiology commercial contracts, and looked at the efficiency programme for corporate departments. We looked at getting in some additional capacity, as the note says, to improve our position on endoscopies. And we formally agreed the separation out of finance and investment from strategy and planning, to create a formal separate subcommittee for strategy and planning, and we're just working on doing the terms of reference and the dates and so on to separate that out. People in OD, Miranda?
Thank you, Chair. I'm going to take the summary paper that's included. I'm going to take it as read. There's just a couple of things I'd like to add. The recruitment update doesn't give you the sense of what we were told, which is that we're in the best place we've been for the last 5 years with regard to recruitment, which was encouraging. On the employee relations report, which we looked at, another point to make is that BME staff are no more likely than other staff to enter the process. I think that had been a concern previously. And then on the exit interviews, this was something that the committee wanted to look into and has been looked into by a task and finish group. There's been a deep dive on it and some improvements are being made. So that's an example of the committee in action. We had our annual review and terms of reference, which are shown in the summary. But some of the feedback that came out of the annual review was that I think we needed to maybe do a bit more on the OD side of our agenda and also extend our duties to cover more on OD and also look at sorry, I've lost my thread, but because my battery is about to run out. So I think I'm going to finish there because I think just about everything else is covered. So if you lose me, that's the reason.
Okay, thank you, Miranda. Should we move on to quality and safety, Jackie?
Thank you, Chair. And we had 2 meetings, one in April, which was strategy, and one in May, which was operational. In terms of the strategic papers in April, the quality of the papers was good, and they were addressing the issues that we're focusing on in the strategy. Just to draw out a couple of things, the medicines optimisation was a good report, which gave a high level of assurance on our approach and was quite clear on where we needed to do more work, in particular on patient discharge. And that's picked up in quality account priority perfecting discharges. The infection control BAF, we are green in almost all areas. We had 2 reds that they were turning amber, so there was good progress, and that was being updated with further guidance. And the only other thing I would point out is the deprivation of liberties, new policy coming into force later on next year, and we're already cited on who would need whatever training. So it was a good meeting. In the performance meeting in May, the points that are made there, there was a very good video from a lady who'd had a home birth and hadn't been sure she wanted one, but she was well supported, and it was a very good example of patient-centred care. So the committee was really pleased to see that. The concerns, I think, from that committee was the large waiting list that is now built up and the operational pressures that would bring. We were assured of the patient harm reviews and that we had a grip on the waiting list, but the size of the task is obviously quite large. And then the other concern was about young people admitted with mental health issues and our ability to care for them in the most appropriate environment, which is putting a strain on the children's services. So that was it, really. I'm happy to take any questions.
Great. Thanks, Jackie. Anything anybody wants to raise with Jackie? No. Okay, thanks very much, Jackie. Let's move on to item 6 and the report from the Chief Exec. Jo?
Thank you. Many thanks. So I think the first thing I just want to start with is a massive thank you to all of our staff. You know, we've talked through the COVID time, and it's time to move forwards, but I think we must recognise that we are extremely busy at the moment, and Tara will cover some of that off, both from elective recovery point of view, but also from an urgent care perspective, where I'm sure I know as board members you've been kept updated, but from a public perspective, will have seen the news about the increasing demand on primary care and urgent care services. And those levels of activity are now exceeding pre-pandemic. I think the important thing just to note as well within that is that actually some of that is a good thing, because what we want to make sure is that our public and our patients, where they have got a healthcare need, are coming forwards, and actually that's the right thing to do. That said, it is putting a lot of pressure on our services, and Tara will cover a little bit more off on that. We want to make sure we recognise as well that staff have been working above and beyond now for sort of 16 months, as they always have done, but increasingly so over these 16 months. So Steve, I'm sure will touch on this in his section, but it is right that we make sure that the welfare of our staff, our colleagues, are an absolute priority. You've heard me say before, without looking after our colleagues, we can't do the right thing, look after our patients as well as we would want to do. So we need to make sure it's an equal priority. People are taking their annual leave, which is great, and we're encouraging people to do that. But we're also looking at this time as well for signs of trauma and fatigue as well. And it's important that we do look after ourselves as well as our colleagues and us as an organisation. Steve's going to talk about the staff survey reports, but I'm really pleased to see those, see the results in there. So I won't steal his thunder, but just to recognise from my perspective how pleased I am with those results. And we can talk a bit more in a little bit about where the corporate priorities are. But as with always, we're looking for continuous improvement. The job's never done, and we'll strive to continue to do that, which is the right thing for our staff and our patients. I mentioned last time that our vaccination programme is coming to an end. We have concluded that from a hospital hub perspective. Clearly, the national programme is still in place. We ended up vaccinating 25,000 people, so 50,000 arms, as it was put to me, and that was across the health and care sector. And just to give you a flavour, our substantive staff's around 7,500. So the additional people we vaccinated were our health and care colleagues across not just East Sussex but wider. So it's great that the trust has contributed to that. And when we had the celebration at the closure of the hubs, I did say together we have saved lives, and I think that's important. I just want a big shout out as well. 500 people were involved in the 2 vaccination sites. Some of our colleagues on the call as volunteers or as vaccinators, and we are, as you might expect, looking towards the autumn when a 3rd dose is likely, and we need to think through with the ICS and system partners what that looks like for a winter vaccination programme. 97% of our substantive staff have been vaccinated, which is absolutely great. My shout out, as I would always do, is that when people are called for their vaccinations, I think the over 25s or 25 and overs have just been called, it's really important that people come forwards, and if there are health concerns, then obviously discuss those with your GP, but I'll always plug that whenever I've got a chance. So what have we been doing sort of the last couple of months since board? So we've talked about COVID a number of times. It's now time to look forwards, and we've been doing that over the last couple of months in particular. So whilst we're still recovering from the 2nd wave and it's not over, as you'll hear from colleagues as we move forwards, the future and focus really is around the planning and delivery of recovery of our services, and Tara's going to talk about that a little bit more. That is in the context of the integrated care systems, so the Sussex plans, and I'll come on to East Sussex in a minute. Those plans were submitted on Wednesday, the final versions, and we will bring back a report for the next public board and a progress update against how we're doing. But again, Tara's going to give you an update in terms of the elective side of things, and Damien will talk about the financial planning. As I say, those plans were developed as part of the wider ICS submission. We're now working with East Sussex colleagues across health and care from East Sussex plan, and that is due end of June. And again, we'll be able to bring that back to full board. And you will see an increasing focus on health inequalities and population health, certainly within, well, in Sussex, but also the East Sussex. We have got excellent collaborative arrangements in place with the local health and care partners, so it's really a case of building on those through our local planning and delivery over the coming months and years, actually. The plans are in, and we have circulated this previously, but from a public perspective, it is obviously in line with the national planning guidance, and that was issued at the end of the month, end of March, so we haven't had lots of time to pull this together. We've submitted some additional funding bids in support of the Ockenden requirements in terms of additional consultant cover and some midwives. We've yet to hear back on that, and that's pump priming for this year. And we've also submitted bids for our community teams to enhance the 2-hour urgent response services. And that's in support of admission avoidance, so step-up beds, as some people might know them, which allows patients to remain safely in their own homes and avoid hospital admissions where it's not needed for that particular patient. We've also been working on developing the overarching trust strategy and the underpinning transformation plans. Again, once those are, although the transformation plans will take a while to fully work up, we will bring that to the next public board and share that with everybody. Just a last couple of bits from me, really. We reported last time about the strategic outline business case for the hospital development programme that was submitted at the end of March. We reported last time. We're working with the national team, or we will be working with the national team on next steps and timing, and any funding that's associated with working up the outline business case. But we'll keep people updated on progress against that. But I thought it was important to say that there isn't an update other than what the update I'm giving you now. Yesterday, I thought I'd just bring in a couple of capital bits. So we're moving forward with the procurement and delivery of the cath labs at Eastbourne and Conquest in the latter half of the year, and expanding the emergency departments in time for winter. And lastly, I visited the Conquest I visited the nursery at the Conquest yesterday. And I'm planning my revisit. They have glitter, glue and bits of paper, so I was in my element. They've done a fantastic job, actually, and we really should reflect the services that have actually helped support keeping our staff at work. And it affects, the staff well-being, and I know at least one of our board members is benefiting from that as well. But even more exciting is the fact that the new nursery is going up. And for those that are at the Conquest site, you can go and have a look at it. It is a building site, and the children go and have a look at the diggers and the cranes. So it's quite an exciting little adventure for them. So I thought I'd end on that note because that is truly exciting, and I look forward to watching that go up over the next few weeks and months. So that's my report. Thank you very much.
Thanks very much, Jo. Questions from colleagues for Jo? Amanda.
Jo, thanks, and share your absolute gratitude to staff for managing through such turbulent and difficult times, and also recognise how busy we are, not just with backlog, but actually everyday demand. And it's on that note, Jo, that I just wondered if there was any update on how the enhanced 111 service was impacting on demand, and any thoughts on that as we prepare for winter?
So I'm going to bring Tara in to answer that bit because I know she's got a little bit in her section, and it might be worth just. And
it can wait. It can wait if it's
That's right. So yes, because there's a task and finish group looking at what's happening around the increased demand. So if Tara's happy to pick that up, then I can.
That would be great. Thank you.
Okay. Well, if there's nothing else, Jackie.
Sorry, Steve, I couldn't find the raise the hand button. Jo, just you mentioned about possible third vaccines and thinking about flu jabs as well. Are we excited yet on roughly the timescales for flu jabbing and or vaccinations, because that could be quite a very heavy burden, couldn't it?
Yeah, so I'm going to loosely say autumn. Richard may want to come in because Richard's been leading, well, to be fair, lots of executives have been involved in leading the vaccination programme, but currently sitting with Richard from the COVID perspective. So there's a couple of things. We know it's likely to be autumn. We understand that the flu vaccine and the third dose of COVID can be co-administered. We'll have to look at what that means for our internal programmes, and there are discussions on that. There are discussions from an ICS perspective. As you know, when we do our flu peer vaccinator programme, the vaccines are kept up on the wards, and that's how we managed to get such good success. I'm not quite sure it will apply in the same way for COVID, so the COVID vaccine. So we'll have to look at that whole programme over the coming weeks, really, because I don't think we've got that long to plan for it. So I don't know if Richard wants to come in or anyone else, but we'll obviously keep you updated on that. But autumn is looking like the right time.
I'd only add one thing, Jo, which is we're obviously awaiting guidance from the ICS because it's coordinated at that level, as you say. And I think, Jackie, your point was alluding to the effort involved. Part of the question will be how much of this, given that previously the vaccine was partly done in the community but began in hospital hubs. I think the conversation is how much of this gets rolled out through community hubs versus in a hospital hub, which of course we've been very effective, as Jo's pointed out, but it was a significant upheaval in terms of what needs to move around to accommodate that particular bit of work that we did. So we're waiting for ICS guidance, and we'll be negotiating with them on that when it comes through.
Okay, thank you.
Thanks, Jackie. I mean, I have to say, given that we did deliver 25,000 doses, if we were able to offer that kind of service again and minimise disruption to our own services, etc., that would be better than putting another 25,000 doses back into the community. I think if we were able to do it, but great. Okay, thanks very much, Jo. Let's move on to the integrated performance report. Start with quality and safety, and Vicky and David.
Thanks, Chair. So I'll start as always and then hand over to Dr. Walker. I'd just like to add my thanks to the nursery staff. They came to the rescue for me before wave one, when unfortunately for our daughter, with 24 hours notice, her nursery was shutting with nowhere to go. So they've been fantastic. And actually, although her previous nursery then reopened, we were so happy and she was so settled here that she's stayed ever since and absolutely loves it. And the staff have just been extraordinary. So I know Steve is very proud of all of them, as he should be. They do an extraordinary job. And with toddlers, there is no social distancing. So they've just been amazing throughout. So just a couple of things I would want to highlight. In terms of COVID, we do currently have one inpatient, but levels currently still remain very low in terms of prevalence and the local population. However, we are still very vigilant and work is ongoing to ensure that staff continue to follow all of the infection control guidance and the PPE requirements. As Jo says, it's been 16 months now, it's been a long time, and we're mindful of everyone having a little bit of fatigue. So just continuing that message to all of our staff to make sure that they stay vigilant. Clostridium difficile limits still yet to be published, and our year-end position was well within the limits that we had set ourselves. We did see a small increase in April and in May, but that hasn't shown any themes or causes for concern, and maybe a side effect of appropriate antibiotic use in terms of COVID pathways for patients. We've had no outbreaks and there's been no links in terms of ribotyping, so no concerns for me. In terms of harms, pressure ulcers and falls are well within expected ranges, and our falls rate still well below the national average of 6.6. and looking forward to the medical and urgent care division coming to the quality committee to present their ongoing work about falls prevention within the specialities. In terms of patient experience, April did see an increase in complaints, so we are now back to pre-pandemic levels. The work on clearing the backlog continues, and the central team and the divisional teams are busy and working very hard to try and help get through that backlog. In terms of friends and family tests scores, scores overall are extremely positive, but there is just a review underway in some of the outpatient areas where some of the scores are slightly lower. So I've had some discussions with colleagues there. Workforce, I'm sure Steve will provide far more detail, but very pleased that our fill rates for nursing remain stable. But as Joe has alluded to, activity, particularly in the emergency departments, is high, and the Trust does have additional capacity open in excess of 50 beds at the moment to support that demand. So that's some additional pressure on in terms of staffing, but I'm sure Tara will talk more to that. And finally, just in terms of patient safety, some papers will be coming back to the Quality Committee outlining the new patient safety incident response framework and also our patient safety strategy. And this will be quite a significant change and a move away from the very traditional approach to root cause analysis and serious incident investigation, and much more of a focus on a review of themes. So it will be an important part of our strategy going forward. So, Chair, I'm happy to stop there if there's questions. If not, I'll hand over to Dr. Walker. I'm both happy to take questions at the end.
Well, let's take David's bit. Oh,
thank you. Sorry, there's a really bad echo.
David, over to you.
Thank you, Chair. So if you turn to the mortality slide, you'll see that both our shimmy at 0.96 and our RAMI 0.88 are better than peers. And for RAMI, we remain just within the top quartile against RAMI for acute trusts, which is good news. As I've explained in the past, both nationally and for us, the RAMI has been going up over the early part of the second wave of the COVID pandemic. And I think the reason for that is that patients knew just how stretched the hospital was, and therefore were only presenting themselves if they really were very ill and in extremis with a non-COVID illness. The RAMI excludes all COVID deaths, I should say, and so just reflects the non-COVID deaths. And so basically the people that we were dealing with were a much sicker population because people were not coming in for routine things, and of course we're not coming in elective surgery and so on. In April, if you look bottom left at the table, COVID has almost dropped off the causes of deaths for April. I think there was one, and we're back to the more usual distribution of things like heart failure, sepsis, stroke, cancer, pneumonia, etc. The table at the bottom right-hand corner shows the total number of COVID patients we've dealt with, and you can see the much bigger second wave starting early December. The red line is the mortality, and the green line are the live discharges, which obviously carried on going up sometime after the mortality had flattened off. We have had one COVID death, I think, in the last month or so, so really the numbers have fallen considerably. I haven't put a slide in regarding harm reviews, but Joe asked me yesterday if I would make a few comments about it. So just before I do that, the policy was written by Tara, so I'll just briefly hand over to Tara just to explain the process, and then I'll just give you some of the highlights of where we are with the harm reviews.
Okay, thank you, David. So the harm review policy is linked to our access policy. It's something that we, as a team in the elective care board and the cancer access teams, decided that we needed to formalise. So to give you a very high level overview of the process, a patient is identified from the patient tracking list, the PTL, or waiting list as it's otherwise known, and that is identified by the length of time that they've been on that wait list. This is automatically populated into a spreadsheet which generates a pro forma. So that's a form that gives all of the patient demographic, and it allows the service management team to actually go through and review the patient record. They then populate that with the salient information, and it is decided whether there needs to be a face-to-face or a virtual review with the clinical teams. So it's given to the responsible clinician who has a review of the records and would meet with the patient face-to-face if necessary. The outcome of that is then recorded onto the pro forma, entered into the harm database, and a datex raised if necessary. Once this is all complete, then it is presented to the medical director, and that will be via the divisional clinical harm reviews or the governance group. The necessary action is taken, should that be further surgery, etc. And then if it's related to cancer, it is presented to our internal cancer board, and then is part of the presentation to the overarching cancer board for Sussex. And for if it's an RTT, so that is any patient on the 18-week pathway, it is presented to the elective care board and to the execs through the IPRs. So that's the process. The policy is obviously live and is due for renewal or review in July 2023.
Thank you, Tara. So if we look at the 52-week harm reviews, there have been roughly 250 or so far. There's quite a lot of what we've called mild harm. For example, orthopedic surgery that's been delayed for several months, and patients have had to suffer with painful joints and loss of mobility for longer periods of time. But in all of those reviews, only 2 were flagged as potentially having serious harm, and both of those have been downgraded after they've had their surgery, where there were concerns that it might become inoperable, but has not been inoperable, and everything has been okay. So far in the 52-week reviews, we haven't turned up anything too serious. However, there is still a backlog, and of course every month a whole host of new cases come on, and so we are constantly updating the list and re-reviewing. In terms of the cancer reviews, there are 132 patients who have not had their definitive treatment yet. Of those, 74 have been returned as no harm, 4 mild harm, largely psychological, where they've had to wait longer for surgery and their results, but there's been no disease progression. 2 are too early to say whether there's been harm, they're waiting for their surgery. 3 have been transferred to tertiary centres for their surgery, and so we're waiting to hear back from them. And there are 21 still pending out of those 132. There are another 51 who have had their first definitive treatment, and roughly 2/3 of those have had their review. Some of them are still awaiting histological results to look whether or not there's been spread. So far, there are only 2 have been flagged as having any harm, and interestingly, neither of those 2 relate to COVID. They're both colorectal patients. One really struggled with the preparation for colonoscopy and twice had inadequate colonoscopies, and they admitted that they'd not taken the preparation as prescribed. They'd had their first dose and had such a profound response they hadn't taken their other doses, and therefore the bowel was not prepared properly for them to see. And then when ultimately they got their colonoscopy, there was a cancer, and the operation had been delayed, but it was delayed partly by the patient not taking the preparation properly, nothing to do with COVID. And the other one was delayed because the patient had other illnesses and major comorbidities and was not fit for surgery, and it took some time to get them into a fit state for surgery. So neither of the 2 harms we've identified in the cancer reviews have so far been related to COVID. However, there is still a significant number that we need to get through, and every month new cases have been added, just as they are in the 52-week non-cancer reviews. So I will bring further updates on this as and when I have them available, Chair.
Great, thanks very much, David. Thanks, Vicky. I've got Jackie with a hand up first.
Thank you, Steve. Just two questions from me. One was on the a number of grade 2 pressure ulcers, 22 in the acute setting. Is there any particular area where this is being picked up, or is it widespread? I know it's still within tolerance, but it looks like a high number. And my second question was around, as COVID falls, restrictions change, how are we communicating quite clearly across the various sites and community? What are our precautions and how well understood are they?
Sure, I'm happy to take both of those. David, I'm sure, may have a view as well. Jackie, in terms of the category 2 damage, it is a fairly even distribution. All of that is reviewed at the pressure ulcer review group with the senior nurses and our tissue viability teams. And we do undertake deep dives, but there's no specific areas at the moment that are kind of flagging in terms of the numbers. In terms of information to staff, we have done some proactive communication recently, a couple of weeks ago, in anticipation of the kind of penultimate easing of restrictions by the government. We were clear with our staff and the public that the national easing of restrictions does not apply to the NHS, and it's important that people understand that. So we've been clear with our staff that everything continues as is for now in terms of all of the infection control requirements and the PPE and social distancing. We have gone back to careful visiting, and that seems to be going well. So it's very good that we've been able to do that. But the message out to our staff is very clear that we are continuing as is for the moment until we get more guidance from the centre, but that hasn't happened yet.
Are we temperature testing people when they come through the front doors? There's two other hospitals and they were doing it when I was last week. No,
we've never done that, and we had a lot of discussion last year, very early on, about whether or not that was the right thing to do. It provides a false level of assurance, I think. There are some places that do that, but actually, I think with the addition of lateral flow testing now being widely available, then we've been encouraging members of the public to do that twice a week. So we've not been checking temperatures, and there's no plan for us to do that.
Thank you.
Jo, I saw your hand go up. Was it on that point?
It was just to say, as Vicky said, we're waiting for the national guidance. That is being reviewed this week, and we would hope to see something over the coming weeks, which will look at all of the IPC guidance, whether that's looking at from a visiting perspective, the testing of electives, sort of keeping the separate sort of electives from the emergency. So I know that piece of work's being done this week, so I would hope we get something over the next couple of weeks, but it may take a little bit longer depending on how complex that is.
Jackie, sorry, and David may allude to this. What I should have said as well is we have for some weeks now, also through the clinical advisory group, been having discussions about how and when we safely de-escalate in terms of pathways, triaging patients and our PPE. So myself and David and Lisa Redmond have been pulling some guidance together. So we haven't just been waiting on the national guidance, we've also been looking at our local prevalence. But as Jo says, hopefully if some national guidance is forthcoming, then that will be helpful.
Thanks. David, did you want to add to that?
Yes, please, Chair. Just to say the so-called Indian variant, which is now called Delta, is the only variant that's been detected in Canterbury, and is sort of 70% of cases that have been detected in Maidstone. So it isn't very far away from us. I saw data this morning from Manchester University Foundation Trust saying that their inpatient numbers had gone from 27 to 49 over the weekend, and critical care had gone from 6 to 10 with COVID. Interestingly, almost all of those patients were young, unvaccinated men with an Asian background. And we do not have a large BME population locally in terms of the Asian population in particular, but we may still be affected by the unvaccinated groups getting this new variant. Although interestingly, it does seem that they're on the whole not as sick, although the ICU numbers have gone up. They tend not to be as sick, and they tend to be managing on oxygen alone rather than having to have anything more intensive. But obviously, Vicky and I are taking all of these things into account when we look at de-escalation. We're watching what's going on nationally, watching the PHE not guidelines, but information as it comes out, and making a decision based on best evidence we have available.
So just a follow-up to that, how are the staff feeling? Do the staff feel that we're doing the right thing, or are we getting any pushback?
I think the staff do think we're doing the right thing. My only, I mean, I really don't think we're heading towards a third wave of anything like what we've had before, and I really hope that is the case. I think that the staff are undoubtedly tired. We've finished with wave 2. We had a very short pause, and now they're into recovery, and we're trying to get the waiting times down for all of the surgery that we've already discussed. We don't want harm to happen to patients because of delays. And also patients are flooding in at the front door, and as Joe alluded to earlier, the pressure on our EDs is enormous at the moment. And so I think the staff are undoubtedly tired. They haven't been able to have really good holidays abroad because that's not allowed for anybody. And so stress levels are high, and I think people would struggle if there was a really serious third wave. But to be honest, my gut feeling is that it won't be anything like the second wave. But we just have to watch very closely, and the figures coming out of Manchester today are a little concerning, and so we do need to keep a close eye.
Yes, they do sound concerning, those Manchester numbers, David, I must say. Vicky,
just back to Jackie's point about the staff and the kind of suggestion of de-escalation. There's some mixed views, Jackie, as you'd expect. So some of our staff, are cautious and a bit concerned about de-escalation. And of course, it's very easy to escalate and much harder to de-escalate, whether that's PPE or pathways or triage. So we've had some really good, robust discussions through the clinical advisory group. But I think David and I and others are very clear that if at any point we need to escalate back up, then we will do that immediately. But I think it's important for everybody and everybody's mental health that we should only be in full PPE when we need to, if we need to. It is not easy to wear. We're coming into the summer. It's getting hotter. So although we've said to staff, if they feel from a risk point of view that they want to wear more, then they can, of course, do that. But similarly, we will be advising what we think is required. And we don't want everybody in full PPE unless they need to be. But people's psychological safety is important, and they're understandably a little bit concerned about pulling back from all of that, but we're doing that very carefully.
Thanks, Steve.
Thanks, Chair. I think it's worthwhile saying as well, we're probably better prepared now than we were for either wave 1 or wave 2 in terms of staffing support. We've doubled the size of the bank. I'll come on to this in my report. We've doubled the size of the bank in recent months, and we're seeing much better fill rates than I think we've seen historically through bank and agency. So we're doing everything that we can do, even whilst things are pressured at the moment. We're doing everything we can to minimise that pressure by maximising the staffing in a way that we haven't been able to before. So yeah, I think as well as David saying, it may well be that it's not such a big peak. I think we're better prepared for whatever peak comes our way as well.
Great. Thank you, Steve. Thanks, everybody. Really interesting discussion. Shall we move on to access, delivery and activity? Tara?
Yes, thank you, Chair. Good morning. I feel like I'm going to be picking up a lot of threads that have already been discussed as we've gone through this morning. So I would take the report as read and just pick up some highlights and really look at April being the month of beginning of recovery. We recommenced our elective programme on the 12th of April. So obviously some of the reports are for full months, but our elective and theatre productivity is obviously related to only a small proportion of the month. We are following the national priorities and operational guidance that was released at the end of March. And although, as Joe said, we're going to bring a paper back to the next public board, I'll just give a quick overview of what that entails. So the expectation is that we'll fully recover the national cancer standards, we'll reduce long waits, we'll reduce the overall size of the patient waiting lists, recover to the highest possible diagnostic activity, to restore diagnostic national standard, and to improve the discharge and transform community services. We were asked to do a model our trajectory against our 1920 activity. And for April, the expectation was that we deliver 70% of that 1920 activity. For May, it was 75, June, it was 80, and July to September is 85. So we're only looking at H1 as it's known, which is the first half of the year, which is April to April. So going through, I'm pleased to give the overview that as a trust, we delivered the national cancer target of over 85% in April. We had only predicted a 76% as part of our recovery trajectory, but we super exceeded that. So we are, it shows that we are working really hard with our patients that are on our cancer pathways. We do expect that to dip off over the coming months, but that is planned because we are treating patients in the right order, and we expect to sustainably deliver the target from August of this year. Obviously, that is dependent on any further waves or surges. We are delivering against our submitted trajectories for April with regards to the recovery at the 70%. In fact, we've exceeded it in nearly every area. And as you can see from the report itself, we are in the upper quartile for the delivery of the RTT. However, that really has been superseded by the recovery trajectory because it is acknowledged that although it's part of the constitutional standards, that 18 weeks is something that we are all, as an NHS, going to struggle to deliver at the moment. As mentioned, we have seen a significant increase in the demand for our services at the front door. On average now per day, we are seeing in excess of 440 patients per day. That is a huge amount of patients that are coming through our doors. We are working really, really hard to support our ED teams, and our system partners are doing exactly the same. And to pick up on Amanda's point and just sort of talk a little bit about what's happening there. As a system, everybody is in the same boat. We are seeing the increased numbers. So with regards to the use of 111 and the UTC, we've set up 3 task and finish groups as a system. One is for the use of throughput of EDs and the urgent treatment centres. I'm the SRO for that. There is another group that is around primary care and the delivery of services in that primary care setting. And the third is around communications. So I can report back from the ED and UTC group, we have had an amazing set of data delivered to us. It's going to take us a couple of weeks to go through it, and it's not often you say this, but the data is really exciting. I actually spent a lot of time going through it myself. And what it does allow us, which I've never seen before, is to actually focus in on the health inequalities piece as well. We can really see our presentations by a postcode, so we know what areas to relate, how to specifically put our messages across, how to improve the access via 111. So we're really looking at how we can improve the 111 use with regards to patients making initial contact, and you'll start to see some posters going up around the organisation itself, just so that if patients come through our ED doors, they can see that they can actually call 111. We're working as part of the primary care and communications group for our holiday makers, because we know that, as we've mentioned, people can't go abroad, so we are on the coast. A lot of people are coming to us. We have been advised that nearly all of the, I suppose, the holiday accommodation is booked up to the end of October. So we're looking at ways in which we can reach these people that are out of area to say, please use 111, and these are the other facilities that can be used. So there's a lot of work going on around there, and I will give you an update in future meetings. But at the moment, we're just going through the group, and they are from every single trust in our system. We have representatives from the ambulance trust, from primary care, health watch are part of each group. We have GPs. It really is a multidisciplinary group. So actually, it's quite an exciting project, and it is a task and finish group, so it's not going to go on forever. So I will be able to report back. We have maintained the expected 25% of our outpatient appointments remaining in the virtual environment, so whether that be via video conference or via telephone. And we continue to use the call reminder service and text reminder services. Now we are starting to see patients face to face again, and we're seeing the increased take up of that, so confidence is growing. So one of the key things that we have to do this year as part of the whole recovery programme, and it's a theme across everything that you've heard this morning, is supporting the health and well-being of our staff. So we're ensuring that our recovery programme does that, and that we deliver the best service possible for our patients, and making sure that our staff get the opportunity to take some well-earned leave. But also as part of that, as the exec team, we are going out and spending a lot of time actually in different parts of the hospital. I myself didn't get the opportunity to go to the nursery and use glitter, but I did spend the day at Bexhill and at the Bexhill Irving unit, and did some ward rounds and looked at the amazing work that's going on there. But also we did pick up some little, as you do when you walk around, some staff ideas as to how we can improve our discharge process and what we can do to support our staff. So we will be carrying those through as part of our, not only of our task and finish groups, but as part of our overall recovery plan. So there's a lot going on at the moment. It is extremely busy. We are trying our best to protect our staff, but we are delivering against the expected targets for recovery, and we are desperately trying to make sure that we deliver the best service possible to our patients at our front door, and achieve the 95% target. So that's it for me. I'll take questions.
Great, thanks very much, Tara. Very interesting. Jackie first.
Two questions from me, Tara, and thank you for the detail. And there is a high level of confidence on my part that we are doing all that we can. But two things strike me: is the diagnostics wait looks really difficult, and so you know, we can't fit a quart into a pint pot. But you know, what other options are open to us? And the other one is the load on ED, and yeah, difficulty accessing primary care, or low thresholds for diverting into ED, and through other things I've looked at some of this. Call times yesterday were 25 minutes to get through to 111. No GPs available in East Sussex for home visits. All of that will bounce to us, and it's not necessarily the right thing for people. So I'm worried about the strain on the system, and that then comes to our front door because people don't really have another choice. And I'm worried about diagnostics and the wait people are having to go through to get that, and what that will do for ongoing treatment. So if anything more you can say on that, I'd be grateful.
Yeah, okay, so I'll pick up on the diagnostic piece first. As some of you may well know, in the early stages, we were asked to prioritise our inpatient wait list with P codes. We now have D codes, so the diagnostic wait list is being classified in the same way that the Royal College of Surgeons did for the inpatient list. So what we're doing as part of that, I can assure you, Jackie, is we're doing an administrative and then clinical validation of the wait list. So we are looking at those patients and looking at how we can prioritise and ensure that our waiting list is clean, because obviously we need to make sure that the data that we're using is telling us the right story. The other thing that we're doing, and again, We have got amazing staff and amazing support from the system because we are delivering above the levels of activity that we did pre-COVID. So we are, activity-wise, we are delivering over and above. We have, as an organisation, just commissioned some additional support for endoscopy. So that allows us to clear our backlog or get our waiting list back to where it should be within 32 weeks. So we will do the prioritisation and ensure that we will make the right patients are seen in the right time. We have additional access to MRI and CT. We are utilising a mobile unit. We've also had offers from our partners at university hospitals, because if we have any issues with regards to long waits or any times, as a group of COOs, we meet regularly. We also have a high level PTL meeting ourselves, and we will look at offering capacity out or support with regards to staff movement as well. So that's just in the process of being worked through. We're very conscious about the need for diagnostics to support the cancer pathways. So again, we make sure we prioritise those patients. It is big, Jackie, but it always has been. So what we mustn't lose sight of is that this has always been something that we have worked, and struggled to keep up with demand. But I think what we are now is in a much better place with support from the system. We have the additional capacity for endoscopy, and the prioritisation will really change the dial on how we look at that wait list. And we will be able to look at the system as a whole, and move into community settings as and where we can. So we are looking at a mobile audiology booth, for example, and that won't be on the acute site, so that we're trying to keep as much out of the acute setting and going with those community diagnostic hub concept as possible. With regards to the front door, yeah, I'm as worried. It keeps me awake day and night. And I think this is the whole purpose of the task and finish groups, because what this does is it really gives us the data set. We're having very honest conversations about how we can support GP surgeries, because if GPs can put more urgent appointments on, one thing that we are seeing, and I'm as guilty as many probably, is that patients, the thought is that patients are ringing and can't get through to their GPs. That's why they're pitching up at the front door. Actually, we've done the qualitative and quantitative data research, and what it's showing is that patients are no longer even bothering to do that. They're just coming straight to the EDs. Because there's an expectation. Patients are becoming more confident now. They're coming out a little bit more. Through COVID, we were providing access to tests, etc., straight away. And I think there's been a change in the culture and the mindset. So we just need to work through these task and finish groups to really look at the communication with patients, what we can deliver in the community, and then what we can do to support, and really look at our urgent treatment centres, how we can improve the capacity there and support 111 as well. And to be honest, our ambulance trusts, because some of the issues that we've had at the front door is because they are experiencing staffing issues. So their profile as well with regards to how they do their conveyances, it shifts. And there's some days that we can have not a lot during the day. Richard and I were on call over the weekend, and we saw these peaks and flows in the way that the conveyances were coming through. So I haven't got an answer. I wish I did, because I could bottle it and make ESHT a lot of money. But we are working as a system through the task and finish groups.
I'm just worried if we're at this level now, when we go in towards winter, it's just going to be very, very difficult winter. So thank you for that. I remain worried, but
yeah, I'll join you with that. But we are working through it.
Thanks, Tara.
Thanks, Tara. Nikki.
Thanks, Steve. There's a huge amount of data here, Tara, which in some ways is great, but it also feels a little bit confusing. I wonder if you might just be able to focus this for me. What are the three things that are keeping you awake at night? And it may be that you just say, well, I've just talked about ED and that's one of them. But what are the three big things that are the highest concern for you? And when we're talking about this in 2 months' time, how would you hope that they might have changed?
I think, to be honest, Nikki, the biggest thing is going to be the ED, is actually the pressure at the front door. And can I say that I will have changed that in a couple of months' time? I will have done my best to work with the system to ensure that we do that, but obviously it's around the whole part of influencing that patient journey. I think diagnostics is another one, and that is because there is a big demand. It's so important at the beginning of the patient pathway. And not only do we support if our patients coming through on elective, we also support the screening programs as well. So I think there is a demand there, but we are again looking at how we can address that. And I think the third thing, if I'm perfectly honest, it doesn't keep me awake at night, but I think it's something that we should all be very conscious of, and that is the demands and pressures on our staff. And it's I sit there every day and ask the same people the same questions. So it's really making sure that they feel like we are supportive, that we're visible, and that we're working alongside them. So I don't think it's one of those things that is worrying me as in the same way that ED is, but I'm very conscious of the fact that we need to make sure that they are at the centre of nearly everything that we're providing. Because obviously if we've got happy staff, then we'll have happy patients.
Excellent, thanks, Tara. Miranda.
Thanks, Chair, and sorry about various IT troubles, which meant I've had to switch to a different device. Listening to this, it just puts me in mind almost of the first and in particular the second wave of COVID, because it sounds as though we are kind of beset by a huge amount of demand, but of a different kind. I also feel very assured by the things that you've said, Tara. I suppose my question is really, is there any help from the centre for any of this? Is the centre and the system doing all it can to help us with it? And is there anything that we can do on the board to help you in your task?
So thank you, Miranda. With regards to is there support? Yes, the system are very supportive. I think probably I'm seeing an increased level of collaborative working. I know that I myself am part of, we call ourselves the round table, but the COOs, we come together every month, and in the last couple of months we've done it face to face. We've whiteboarded some of the exercises and some of the issues, so we really are getting down into the nitty gritty. So system is very supportive. Obviously there is only a certain amount of resource, and probably that is the thing that we're all drawing down the same thing, but we're going into it together as a system now rather than each competing against each other. Centrally, yes, again, there is the support there to provide, and we have the ERF, which is the Elective Recovery Fund, and we're working to see how we can draw that down. I suppose there's always little things that you could say, is there anything we could do differently? We have to report against everything we're doing, and that sometimes seems to be a very quick turnaround, which puts pressure on people. As a board, I think we're already doing quite a lot, and I suppose just continuing to be visible, and I'm more than happy to take some of you round and meet the teams and talk you through and show you how we actually do cope with some of these pressures and processes as we go forward. So, welcome the support all the time.
Thanks, Tara.
Thank you, Tara. Amanda.
Sorry, I won't repeat everything that everybody's said, but I will take the opportunity of saying you have such a confident way in describing the data, and it's really, really helpful. However, I am intrigued by one thing that you said, your excitement on this new data. So excitement and data is a little alien to me, so bear with me. I just wondered, so you're talking about using the data to really drill into population health needs. You've got the construct of your COOs meetings, the roundtables, etc. We've got great partnership working, and all of those things are real foundations for doing something remarkably different. However, what is your view of how we can cut into this demand management in a different way? Because we are going to have to do something quite radically different. And whilst I hear there is support, there's new data, we've got all the tools that we need, what I want to understand is what you think will be different in 3 months, 4 months time, that actually drills into our population and their needs, and how will we work in partnership to do something different. So does that make sense?
It does, yes.
Yeah.
I'll try and I'll paraphrase it, because I could go, like I say, I did get excited about data, and for those that you know me well, that's not really, I'd rather be out doing things, but actually the data that we've seen come through from the system really does allow us to look at the presentations of patients from particular areas. And I'm going to focus on that, Amanda, because that's where I think we can make a difference, because it's understanding why those patients are coming direct to ED. And really working with those areas. And it might be that we need to look at the community settings, or work with churches, or do whatever we need to do to get the message to those people to say, these are all the alternatives that are available. And understanding things like, you know, digital discrimination. So maybe they don't have mobile phones, maybe they don't have access to internet. So it's really old-fashioned letter type drops, or, you know, people like myself or whoever going out and having those conversations at different groups. So we're looking at all of those different options. It's not going to make a huge difference straight away, Amanda, I know that, but it's going to start make those differences. And the other things I think that we've got is, and it's quite exciting, and we're working it through, is working through with the chiefs of service as well, and looking at different ways of delivering care, and actually that discharge care, and how we can provide capacity in the at the discharge end to allow flow for patients through the hospital without actually having to have a patient in a physical bed. So, you know, in my mind, I'm calling it ESHT at home. And it's how we knit all of the different digital solutions, and we used pulse oximeters in COVID in the first and second wave. How do we pick up little bits like that and make virtual space for us to be a hospital that reaches into the homes and supports patients at home, so that they don't feel that they have to come in or put pressure on the system. I'm quite passionate about it, as you can tell. And the task and finish groups, and you know, myself, Richard and his team will be working and knitting that all together over the coming months. I'm not saying it's going to deliver straight away, but we have got an eye on winter. I'm taking the clinical chiefs away for a session on Monday, and as I've already said to Joe, I've had cupcakes made, and winter is coming is the little slogan that's on top of them. So it's to keep them focused.
But Tara, I think what you've said is really helpful. The most important thing for me is that clinical engagement in this solution orientation. So thank you for emphasising that.
I love the idea of cupcakes with winter is coming. It's Game of Thrones meets British Bake Off. Very good, very good.
That's what I thought.
Joe, did you have a hand up?
Well, I don't want to add to the conversation, because I think we've had a good conversation around it. I suppose just 2 points, a couple of points from me. One is, this is a national problem and it is recognised nationally, and there are discussions at that level. That doesn't mean we've got solutions out of it, but once you've got the national team on it, then they will look for some support, which does often make a difference. The other thing I would say is that whilst we've always worked together as a system, actually this is a Sussex-wide approach, whereas we've done it very much as sort of an East Sussex level, and the response from the wider Sussex system to do this task and finish group, I think, is over and above what we've seen before. I also think we need to separate out there's two different bits of demand coming in here, and I'm not talking about the electives. One is that walk-in quick turnaround primary care presentation, and the solution to that is very different from those that are coming in for admission. And in essence, really, other than redirecting, it's a workforce issue for most of those. So I think the task, I think we can come to a solution on that. And the other, as Tara's already said, actually this is an opportunity to be really innovative, because we're going to have to rewrite the rules here. So I think be creative. So I'm equally worried about winter, but I'm optimistic that certainly the front door quick turnaround patients, primary care patients, that we can get a solution. It's just happened quicker than the numbers went up quicker than we could possibly have anticipated. That was all I was going to say.
Great. Thanks, Joe. Miranda, is that a legacy hand that's up or a new point?
It's an old hand.
Okay, thank you. Thanks, everybody. Really interesting conversation. That very helpful, Tara. Thank you. Shall we move on to workforce, Steve?
Thanks very much, Chair. I'm conscious that we've already talked around a lot of the things I was going to touch on, so I'll take the report as read and move through just a few key points. Before I do that, I'm also very conscious that whilst I've told people individually, we haven't formally informed the board about the sad death of Sue Esser, who's my deputy, who was my deputy in my team. She died on the 17th of May at Martlett's Hospital after an illness. Her funeral was yesterday. I just personally want to pay tribute to Sue and to thank Sue for the support that she gave me when I joined the organisation. I worked with her for a short period of time, but her support was invaluable in that time. I also want to pay tribute to my team who have dealt with this in such a professional and exceptional way. They've maintained services, they've kept things going. I know it's been very difficult for them, and I just want to publicly thank them for everything that they've done over this period and the support that they've given me and the organisation over the period. It's been quite something.
Very well said, Steve. Very well said.
Thank you. Moving on to the report itself, I think this is a particularly interesting report for me because it's the first month in which we're sort of coming out of the back end of the COVID staffing pressures, in performance terms at least, and moving into a different set of pressures which we've already discussed in some detail. We showed a slight underspend on pay as we predicted we would. It was down 18% on previous month as well. Our bank and agency usage were both down. Agency usage was down by 30%. And with our much larger bank now, which, as I mentioned earlier, is up 100% from 3,000 to 6,000 over the last 4 months, our fill rates are much higher, and we're now running, or certainly in this period, we're running at 77% fill rate, which is very high for us. Our budgeted establishment's been reset over this period, as we discussed at previous meetings. So that takes us back to a more realistic picture of the vacancies that we're carrying, which are now up from minus 0.5% to 4.6%. This is helpful in terms of being able to sort of formalise, our recruitment going forward. Monthly and annual sickness continue to drop. MSK back and stress and anxiety, interestingly, are all lower than they were in the same period last year, but they still represent significant areas of focus for us, and the staff survey particularly brought out MSK. I think the interesting thing with MSK is that its prevalence through staff survey, or its awareness through staff survey, is going up. Its prevalence through it being reported as a reason for sickness is going down. I would hope that some of that is through people just being more aware of issues and reporting them, taking more care of themselves. COVID levels amongst staff are much lower than the maximum of 237 we hit. As at today, and this is obviously different from the report, we're at 13 staff who are reported to be sick with COVID. Lateral flow tests have only showed one positive in the last number of weeks, and in fact that was followed up by 2 negative PCRs. I think one of the challenges for us is to keep staff reporting. As there's less sickness about, it's easier to think, oh, that's okay, and stop reporting. So we're keeping a real focus on lateral flow tests and reporting, because the last thing we want to be doing is obviously bringing it into the hospital. In terms of our compliance against standards, we're working really hard in this area, and I'm pleased to report that whilst we missed the target, our mandatory training compliance is now at 89.6% against a target of 90%. I've been back through our records, and whilst we haven't hit the target by 0.4% this month, this is the highest we've ever recorded, the highest compliance we've ever recorded. And I would hope that next month, we will hit the target with a fair wind. Our appraisals are at 74.9%, up from 73.2%. In the previous month, the target here is 85%. There's more of a gap against target here, but I would like to remind the board the actions that were taken to stop appraisals at a national level over the COVID period. We have recovery plans in place and we're working to those. I think Vicky's already mentioned recruitment. Our performance in recruitment continues to be strong. We're recruiting more people more quickly than we ever have before. In terms of our international nurses, for example, we've got a pipeline of 185 that we believe we will hit by the end of the year. We are continuing to focus on job planning, and all of the divisions are engaged in this. Clearly, as we look to recover services, job planning is particularly important to make sure we've got the right people doing the right things at the right time, and all of the divisions are very, very focused on this. Health and wellbeing has come up a number of times, quite rightly, in the board so far, and it continues to be a major area of focus for us. Joe asked me a couple of weeks ago, what's different about health and wellbeing now? Because it's feeling different. It's feeling, that our support is more positive. People are being more positive about things. And I think I would summarize that by saying, actually, we've moved from offering solutions and offering options and offering support to embedding solutions and embedding support. In other words, we're actually putting it much, much closer to the time and place of need. Some examples of that, I'll give you two, TRIM and mental health first aiders. So TRIM, the trauma management approach, is now being offered across the trust. We've got 25 people who have completed training, 38 who have started training, 51 who have applied to do training, and another 115 people who have expressed interest in delivering TRIM. Now, you can imagine when we've got those sort of numbers across the organisation, our ability to be able to react at the time and place of need, as opposed to people being in a queue, is much, much better. Mental health first aiders is another example. We have 64 trained mental health first aiders now across the trust. We have another 48 who are booked on courses, and we've got over 100 people who have expressed interest in booking mental health first aid training. One of our mental health first aid trainers is on the call today, Vicky. I know that it's something that you've undertaken, and I think you got personal value from it and are able to deliver value from it. So thank you for being a part of the team that are doing that. I should say that actually everyone that does the mental health first training actually gets a national qualification through doing it. So not only are they contributing to the to the welfare of people across the trust, we are able to offer some recognised growth and qualification for people as a part of that. Another thing we're doing, it's the last thing I want to touch on in the report, is this week is National Carers Week. We recognise that many of our staff are carers in different ways, and this week we're introducing the Carers Passport, which is a way in which we can recognise further the needs of carers and make sure that that we're supporting those needs. So I just wanted to touch on that again at the end. I think that concludes the main parts of my report. I would have touched on staff survey, but we've got a separate item on that later, so I'll come back to that at that point. Thank you.
Thanks very much, Steve. Very comprehensive. A number of hands up. I think Karen was first out of the blocks.
Thanks, Chair. And thanks, Steve, for a comprehensive report. I see you mentioned that there's going to be a national review on long COVID, but actually by the number of staff off sick with COVID, obviously, I think we can say we don't have a major issue with long COVID per se. We've put in place lots of things for mental health and obviously getting great uptake there. What information do we have on impacts of COVID on staff? So I'm really thinking more of the physical impacts that don't really qualify as long COVID. So I'm thinking particularly around fatigue and just kind of reduced physical resilience. We do have an older workforce, and I wonder whether we are tracking that, because if we have another surge as we go into the winter, what's our level of understanding, and how can we respond for those staff who yes have just been impacted in the long term with COVID, but not actually having long COVID?
Yeah.
Hope that makes sense.
Yeah, yes, it does, Karen. I think it's a really interesting question. I think we're sort of in a little bit of so we're in a calm. We're certainly not in a calm, but in data terms, I think we're in a calm between potentially two storms. One being the number of people that were off sick with COVID, and to be honest, for other reasons as well. I don't think it is just about COVID now. I think there's a whole broader range of reasons that people might have been off ill because of the pressures they've been under. I don't think we are yet seeing fatigue and a broader set of those broader set of challenges coming through within our sickness numbers. You know, our numbers are still going down, but I think the point underlying your question, which is, are we keeping an eye on people going forward? Firstly, I am concerned that numbers will go up for different reasons, because people have stopped running, they've stopped sprinting, they take some time to reflect, they take some time to breathe, and we've all been in that position where we've been dead busy, we stop, and suddenly we get hit with something. I am worried about that. We're doing a lot more things like team check-ins at the beginning and end of shifts, individual check-ins. We're actually changing our appraisal process to simplify it and move it more towards more continual conversations. And I want to be really clear that, we're moving appraisals from these are your objectives, how did you do against them, to how are you doing and how are you performing. So there's things we're doing like that. I think what I would say, Karen, is we are trying to put the building blocks in to ensure that we can identify and we can assess these things as they happen. I think we're in a data column at the moment where we don't know what the scale of the challenge is going to be. Now, I appreciate that's not a complete answer to your question, but I hope it gives you a flavour of, well, firstly, the importance we're placing on it, and secondly, the fact that we are absolutely looking out for the signs and we're planning to manage them.
Thanks, Steve.
Great, thank you. Miranda.
I'm really pleased to hear about everything that we're doing on the wellbeing front. Speaking as the board's led wellbeing champion, I recently attended a session organised at a regional level on what the expectations are for this role, and I'm very pleased that we're now getting back to being able to visit teams in order to establish how they're feeling. I think we are doing an awful lot of the right things in the trust. I think we've got some really best-in-class wellbeing initiatives, and I think it's great that there is a different feeling about this now, and in no small part due to the fact that the provision is much closer to the people who need it. So I think that's great, and it is definitely something we need to keep an eye on.
Brilliant, thanks, Miranda. Jackie?
Thanks, Steve. Could I just ask about the EU staff and the mission critical issue of the 30th of June, please?
Yeah, sure, and thank you for that. So just so everyone is aware, settled status is required by the end of June for staff to be able to work in the UK. About a month or so ago, and we've been managing this for some time, we had around 300 staff who we didn't have data for, and I want to be very clear. There's a big difference between they hadn't applied for settled status and we didn't have data. We've been writing to people for a number of months. We are outbound calling all employees now who we don't have information for. The numbers are relatively small now. The vast majority of people who we didn't have data for actually already had settled status, or indeed had citizenship. So I think this was more around people not telling us rather than not doing things. Currently, I'm not sure the numbers as at today, but currently the numbers are sort of just above 100 that we're still waiting for information for. If you ask my level of confidence on it, Jackie, it is high that that we don't have a significant issue. Pretty much everyone that we're contacting has just not been informing us of changes to their status, and we're following it up in that way. But as I say, we are outbound calling full time every day. We have a member of staff set just outside my office right now who is making those calls. She's multilingual. We're doing things like, trying to do it in own languages where we can to make it more simple as well for people, so they really recognise. So I don't see a major issue. We may end up with a very small number of people, but certainly it's not something that we're losing any sleep over at the moment.
What would those staff, if they hadn't got that some sort of status, what happens? What would we have to do as an employer?
We've sought legal advice on this one, as you might expect. Effectively, as at the 1st of July, we would write formally to each of those members of the staff, giving them 2 weeks giving them 2 weeks notice that they needed to provide us with that information, or that they would no longer be entitled to work in the UK. We would also be informing them at that point that the entitlement is not just a work entitlement; it is effectively an entitlement to stay, and that the border authorities may be will be expressing concern at that point as well. So the advice that we've been given is that that letter can be sent with 2 weeks' notice at the beginning of July, and hopefully, if there's anyone outstanding from that, and we sincerely hope there's not with the actions we're taking, that will deal with it. I think the challenge is that for many people who have had settled status or been waiting to get it, it has been something which I think with COVID and everything else has been sort of off the priority list. But it's certainly very much on it for people now.
Okay, thank you, Steve.
Thanks very much, Steve. A very comprehensive report, and I'm looking forward to hearing about staff survey later on in the agenda. Shall we move to finance, Damien?
So thank you, Steve. Can I just go back to how the budget was set? So what we had for the entire year and now for the current 6 months is that we've had a baseline that was set against months 8 to 10, 1920. In addition to that, we have a funding top up for COVID, and now we have a third element, which is a funding top up for the ERF. What we chose to do in month 1 was catch up locally with where we book the staffing reviews that were looking for, the right level of quality staffing across the trust, which meant basically an increase of over 200 staff in terms of the establishment, and that was recognised in Steve's summary. So that's our starting point. In terms of how the 6 months are going to operate, yes, we do look like we've delivered break even in the first month, and frankly, we now know that we will deliver break even in month 2. There is a surplus being delivered against the elective recovery, of which the first element has to go against our reset staffing, and then there's a second element that is also having to fund the escalation ward that we're currently paying for. The positive in that is at least we know we're on track, and we're assuming we will stay on track through the 6 months. In terms of the fact that Tara has mentioned the target will increase over through to July and then stay at 85% from July onwards. We believe that should be okay, because as our reset staffing has gone through to vacancies, and we're beginning to see substantive staffing increase, what we expect is by July or by June even, we should begin to see a drop in agency and perhaps even bank. So that should be the offsetting benefit that will maintain our break-even position through the 6 months. So in what I'd also like to move on to is the capital position. So we have in total funding for about 24 million. We have a plan for 28 million, which has been discussed through the exec team, through F&I, and also through the chiefs. Yes, there is some allowance for slippage into year 2 because we will begin some schemes at the end of the year, which frankly will carry through into year 2. But it does meet our highest need targets, and it's at least an agreed plan at the start of the year. So this isn't, this is a full allocation of what we should receive as a trust, and it also is part of our share of investment from the ICS. What it doesn't quite figure in is whether there is additional income from the national streams, in particular for radiology and pathology, as those bids happen through the year. So finally, I just want to say our position in terms of the balance sheet is still positive because there haven't been other fundamental movements. We've got agreed funding, and there's therefore the cash flow and working capital is staying relatively positive.
Okay, thanks, Damien. Questions? We had a fairly thorough run through some of this at Finance and Investment, didn't we? Nikki.
Thanks, Steve. I mean, I think you've addressed the key query, Damien, which is how do we grow activity without growing spend? Although these are the results for a while ago, are we seeing that happen sort of week on week? Are you getting increasing confidence that we will hit that? And then the sort of second question is, in a similar vein, it's quite hard still at the moment to get comfort around efficiency and value for money. I wondered since our last conversations whether you'd given that any more thought and whether you had anything more that you could say around that.
So firstly, let's address the activity information. Unfortunately, I can see May's numbers as well as April, which is quite helpful for me. Broadly, we are staying ahead of the target of the 70, 75, 80%. So we are receiving 600 in total, or 630 in total for the ERF component. So it may get closer as we get to July, as we get close to the 85%, but it does look like the operational team are delivering the total target. In terms of the delivering on diagnostics, that's slightly harder because that's planning for direct investment, but you have, it's already identified in Tara's case, in Tara's section, that we've planned in additional resource to help with endoscopy, and that at the moment is factored into the plan. So yes, I think there's some reassurance on that. Delivering efficiencies is a little bit trickier. So we have a plan that has agreed approximately 2 million of the 4.1 million through the first 6 months. To be honest, the plan has taken a major rework to allow for the increased establishment, and we're having to work through a couple of anomalies. And while people have plans for areas of priorities and they're working on those areas, until we can finalize the anomalies in each division, it's quite hard to ask everyone to commit to the detail of those plans through the 6 months. We believe we will get there by the end of June, but we haven't quite finalized the work. And yes, I will certainly give you an update at the beginning of July, well, frankly, at the end of June in F&I, that we've achieved that progress.
Joe.
Yeah, I'm probably going to sound quite operational for a minute. So I think there's what I would call the operational efficiencies. So your normal things of theatres, outpatients. But internally, we have got the Financial Efficiency Committee, which Damien chairs, which does look at both GIRFT, the kind of operational efficiencies bit, and then model hospital as well. And so there's oversight through that. You'll see, and although it's still evolving, there's some indicators in the overarching dashboard within the performance pack that some of the ones that we're looking at, and I know Tara through the elective care board is looking at things like theatre efficiency, which is what the national or the regional programme are looking at as well. So I think we've got a number of things. Some of us do get excited by data and love a dashboard, me in particular. So we are working on an efficiency dashboard, just recognising our BI teams are slightly overwhelmed at the moment by trying to change reporting in line with the national priorities and all the planning submissions. So probably bring back through, as Damien says, through F&I, some of that assurance around those efficiencies, as well as what I'd call SIPs as such. And that's why we're trying to focus on efficiency as well as sort of just cost out schemes as well. And the whole exec have got roles in overseeing that, depending on their areas of responsibility.
Does that cover everything, Nikki? You happy with that? Great. If there is nothing else for Damien, let's move on. Thank you, Damien. Learning from deaths, David?
Thank you, Chair. So I think you're all used to the format and the structure of these reports now. I've been bringing them to board for a few years now. So points to note, if you look at page 1, the graph on the right-hand side will show you that finally all of the deaths are now being reviewed, and that's due to the successful introduction of the medical examiner system. So there's effectively an independent review of all of the deaths. This quarter, there was one death that was considered to have strong evidence of avoidability, and that was a death that was one of the SI deaths, which we can talk about. If you look at the overall number of deaths, it's interesting. There's probably about a 10% increase in the total number of deaths this year, and effectively it's the calendar year that this report looks at. Quarter 4 through to quarter 3 this year, about a 10% increase at 2027 compared with 1942, and that's really due to increased deaths in wave 1 of the COVID pandemic, and then just the start of the excess deaths in December. But of course, the biggest impact of wave 2 will come in the next report, and so we're always reporting slightly behind. The one avoidable death that we're reporting this quarter had nothing to do with COVID, I can assure people. And I'm happy to take questions on any of that.
Great. Thank you, David. Questions? All crystal clear then, David. Thanks very much. Good. So that's according to my agenda, that takes us to a planned break. So let's draw close. I think we're scheduled to restart at 11:30. So I will see you all then. Right. Welcome back, everybody. I make it 11:30. Let's get underway. Before I turn to Richard and the white paper, I want to just say something I should have said right at the beginning, really, which is that this is Joe's first public board meeting since having been formally appointed as the Trust's substantive chief exec, and I'm slightly embarrassed that I had to be reminded of the fact during the break. That's what you need a good HR director for. And so Joe, just formally on behalf of everybody, congratulations on your appointment. I think most people on the call will know that you know, there's a big national recruitment exercise, and you were put through a pretty daunting selection process that even as the architect of it made me wince when I thought about what you were having to go through. So congratulations, Joe, and apologies for not having said that at the top of the show.
Thank you. And as you all know, I'm absolutely delighted to be able to carry on. So thank you very much.
Good. So thanks. Let's move on to the white paper and Richard.
Thank you, Chair. Thanks very much indeed. So this paper is here, as it says, for noting formally with the board, as members are already well aware of the implications. This almost feels like old hat, since we've discussed at length the issues and the implications of the white paper at our recent away day. It was published in February, and we think it will receive its first reading in Parliament in July, so next month. I suppose what I would really want to do, I've kind of tried to summarise the main points of the paper. There are a couple of elements I draw out just for the board. I'll take the paper as read, but points of note for Sussex. I think when we've discussed this before, there's a bit of a tale of two cities in the white paper, really, which is, you know, best of times, worst of times, lots of change, no change at all. In Sussex, there's an awful lot that already exists. So we have an ICS that's functioning. We have a strong collaborative system working through Sussex Acute and the primary and community care networks already, where we are present and we play our role in that. I think place, while not mentioned explicitly in the proposal in the white paper, is already well advanced, and that again goes back to this history of working together with the local authority in East Sussex. And I think what's noticeable from the ICSs that are already in shadow form working across the country, where they work best, they move at the pace of trust, and where trust is strong, then those ICSs can get a good foothold. And I think we recognise ourselves as in that category. So I think the first point is there's a lot in this white paper that we're already seeing as nascent in Sussex. The second point I would move to is really the cultural change that I think we need to reflect on this paper heralding. We have come through almost 10 years of the Lansley Act, the Health and Social Care Act, passed in 2012, where it talked really about the atomisation or the fragmentation of the NHS. It was all about individual organisations as the units of measure. Market share growth was an imperative. Minimum sizes were talked of for trusts, and mergers and acquisitions were kind of an expected feature of the operating environment. And what we've got in this new legislative framework is a real volte-face. From 2022, what we're going to see is the duty to collaborate, reaching across the aisle to NHS and local authority partners, working together for a common cause, focusing very much on outcomes, not inputs, more and more. And I think Steve has talked about this in the past, but the OD implications for us, not just as an organisation, but individual clinicians and staff, of what this means for our ways of working, I think will form part of our OD strategy, which will run alongside that new strategic plan that we've already talked about coming forward for the next 5 years. So I'll stop there, Steve, and ask for board questions, but I think those for me are the two main takeaways in addition to what we've summarised in the paper.
Okay, thanks very much, Richard. Questions from colleagues? Miranda.
Thanks, Chair. Thanks for the update, Richard. And I note that it'll have its first reading in July. I just wondered how much will is there behind these reforms in central government, do you know? Because obviously getting something through to statute and then being able to implement it requires a lot of willpower. Is it something that they're going to make time for and are determined to do?
I think so, and I think part of it goes back to what we were saying about the Lansley Act. I think there was a genuine recognition that the environment has not been conducive for transformation and change. Coming through COVID, there was a real opportunity to seize upon moving away from that fragmented, highly organisationally driven approach, to think about if we're going to solve outcomes better, if we're going to tackle those determinants of health that we know have been troubling us and we've struggled with, if we take the context of the Marmot report and Marmot 10 years on, we know that the way that we'll fix those things is by better and more effective collaboration. And I think that's the sort of almost the philosophical underpinnings of this. And obviously, from an efficiency and productivity perspective, there will be an expectation that it's easier and better to coordinate this stuff at a regional level. That's inevitable when we think about how we're going to get measured and how the NHS is going to be assessed. It's very much more at an ICS type of level. That's going to be the operating unit. So I do think it's almost a coming together, a collision of happy circumstances. And I do think that this will get an awful lot of publicity and a lot of support as it goes forward in Whitehall.
I think what's interesting, though, is how much of this feels like Simon Stevens' architecture and design. And as we know, Simon will move on to no doubt greater things shortly, and undoubtedly his successor will want to shape the way some of this gets translated. So I think we shouldn't underestimate the possibility of some subtle changes in emphasis as the new leader comes to terms with the agenda. Jackie.
Thanks, Steve. I was just thinking, the duty to collaborate. We would work more closely with local authorities, and I can see that for adult social care, and it's more on the the house of care model. But how far is that likely to go in terms of our spend? Because that's usually where the barrier will come, isn't it, between health and social care, between adult social care in particular, and hopefully young people. But how far have we got in our thinking about the level of collaboration with local authority?
So I'm happy for others to come in on this. I know Joe and the chief execs have been talking about it, but I think from our perspective, what we're doing at the moment at place level certainly is dusting off the old plans that we had around health and social care integration, how that comes together. What's quite interesting is obviously you'll know from the Act that when we think about the financial envelope, that's an NHS envelope across Sussex. What we were hoping, and it's kind of gone a little bit quiet, is in the Act, in the proposal itself, the white paper talks of additional forthcoming plans for legislation around social care. And obviously, when you talk to colleagues in local authority, what they're saying is, well, of course, the numbers and the money will all get sorted out when we get that additional legislative framework. That at the moment doesn't appear to be forthcoming, and that's kind of lost in the mist a bit. So I think the money side of it, I'm a little more concerned about how we square that off. Not from the NHS perspective, because we know that that's covered by the white paper. But I think you raise a really good point, Jackie. We'll all sit around the table and work together collaboratively, but I think unless we can have some steer around what's going to happen to that social care funding and funding streams, then it's going to be that there's a potential barrier there. Joe's hands up as well, I think.
Just to come in, so we often use the words collaboration, integration and partnership, and they all mean slightly different things but can be used in a similar context. As you know, we already have integrated teams under single leadership in our frontline community services. I think there's three bits to me, really. There's a bit about, as you said, the collaboration and working together for common goals, and they'll be reflected in our East Sussex plan. That's the first step that we need to do. We will continue to look with the local authority at what I'd call integration, so joint teams. They're not necessarily the conversations at the moment. I think we need to understand what our priorities are, but those conversations will continue to happen. And then we come to the how far do we want to take this, and that's the potentially pooled budgets, single budget for between us and local authority. It's not part of today's conversation. I think it could be somewhere we choose to go in the future. But what we want to do is make sure we focus on the priorities for this year and next year. So it's not off the cards, but it's not immediate conversations at the moment. And I think we'd need to be really clear that health and care don't lose out with one supplementing the other potentially. So I think it's a conversation that will be had, but not quite yet.
Okay, so just a slight follow up to that. So other voluntary third sector organisations that are giving care now, will we have an engagement process where we can start to work with the voluntary sector or private sector in terms of some of those pathways?
Yeah, so I suppose a few things. So part of the East Sussex plan is making sure that we've brought health and care, and I should say then that the third sector into that. Within East Sussex, we have an East Sussex executive group which has all the health and care providers, or health and care NHS providers and the local authority. We then have a partnership board which reports into the health and wellbeing board, which includes the third sector in there. The place-based plans will look at, as we said before, health inequalities, population health and pathways, and those pathways will and should include the third sector in that, and we have got some of that work already happening, but that will be more upfront and centre, making sure we're using all the resources that are available to us. So the mechanisms are there, we just need to drive that bit a little bit further and faster now.
I think just going back to the local authority, obviously we had the recent local authority elections, so that's given us both kind of political and some personal continuity to continue. I met with the local authority leader last week, just after he was announced as continuing as the leader. His enthusiasm for the kind of integration agenda is undimmed. He's keen to be as ambitious around this agenda as we are, keen to do things that make a difference to patients together. So I think all of the foundation work is really there, not just for us to get through this, but to thrive and really succeed. We're probably best placed than any other NHS local authority partnership that certainly I've ever seen before. So I think it all bodes very well. Amanda.
Thank you. It was just, I agree, a helpful paper, Richard, and as you said, we've discussed this at length in different fora, and this duty to collaborate, integration and partnership, all those words that we use well, and I do think we're positioned well to do something quite remarkable for our population. There's the kind of difficult, thorny issue of governance and accountability that I know that people are grappling with at the moment in terms, and I know that we've got support through the ICS to do that. I just wondered when we would see some outcomes from that, and if you could say a little bit more about the timetable for establishing to meet the criteria of April 2022, which isn't that far away when we think about it. So obviously bill has to go through Parliament, but following that.
So I will start with the last question, and I think Joe can talk through some of the support that's on offer around the governance through the Good Governance Institute provided to the ICS. So I think in terms of the progress that's being made, there is a very high level plan to have in shadow form from autumn the new structures of the ICS. I think in terms of our engagement, it remains on those collaboratives, the main force through which the transformation will be delivered and evidence through into the new body that we're expecting to see in shadow form. We're going to be those collaboratives, and we will retain our own visibility at each of those. So I think what we're looking for in the autumn, post summer holidays and people come back, is what then we think the ICS is going to frame and shape up in terms of its priorities. And I think that will probably be driven by things like Vision 2025, which is the strategy document they already have in place. Joe, do you want to talk a little bit about governance and architecture? Because I know there's been some thought on that.
Yeah, so I'll try and shape without filling in too much detail about some of the conversations. So firstly, so the ICS has yet formally to, well, we'll be going out for a chairman and chief executive. The chairman, the post for chairman will be run as a national advert, in fact, the same for chief executives, once the bill has been passed. Then those posts will be appointed to formally at some point, sort of between sort of July, assuming it happens in July, and sort of the coming months afterwards. That said, the current chair and chief, ICS lead are engaging the chief executives and the DASs, the directors of adult social care across Sussex, in helping to think through what that governance will look like. I don't think it's right necessarily to share all of those discussions in the round, because they're just evolving conversations really. But the sorts of things we're talking about is, what's the shape of the ICS board? Where does where do the chief executives and the boards of each organisation fit within that structure? Because the ICS will be a board in its own right. We are having conversations about where performance management sits. Is that at place, or is that within the ICS? Because that will be devolved down from region through to the ICS, as we have been doing, to be fair, in their shadow form anyway. We're sort of talking about what place responsibilities are, but I think it's fair to say that they really are around pathways, inequalities, population health, local transformation and primary care, so that we're not duplicating things at place level that we're talking about at the system at a Sussex level. I think, you know, there are still some challenges around, you know, as chief executive, I'm still accountable, and we as a board are still accountable for ESHT, the organisation, and some of these things still have to be worked through. So I can tell you the conversations are being had. It hasn't been firmed up, but I think it's become clearer as we work through, and there will still be some guidance yet to come out that hasn't been published from the centre. So that's a bit woolly, but the conversations are there, and your points are still valid, Amanda. Yeah.
And they also include the chairs, so that there's a non-exec perspective as well. But a lot to work through and a lot to untangle, I think it's fair to say, before we get to the end point. Okay, well, we're going to be coming back to these issues time and again, aren't we? So so thanks, Richard, for the update. Let's move on to agenda item 10. Is Emma on the call?
I am, yeah. Morning.
Excellent. Hello, Emma. So CNST, do you want to kick us off, Vicky?
Thank you, Chair. Just coming off mute. So thanks to Emma for joining us and for all of our hard work on this. I have been involved, but fair to say that Emma and the teams have done a huge amount of work. So that's why I've asked her to come and present it. Hopefully the board will be familiar with this process and what it entails, and it is a lot of work for Emma and the teams. So I have been involved in that process, but I'll hand over to Emma so that she can just give some context and then talk through the main points of the paper. Thanks, Emma.
Thanks, Vicky. Okay, so yeah, the CNST maternity incentive scheme has been running for 3 years now, and the requirement is for us to pay an additional 10% premium and then evidence the safety of our service under 10 safety actions to be able to achieve rebate of that premium, that 10% of the premium. So it's worth a fair bit to the trust. The two years have rolled into one, obviously for obvious reasons. So last year's premium rebate is 323,000, and this year it's 475,000. So it's a lot of money, and some of that money will be reinvested into maternity safety initiatives. We have been able to achieve the evidence for all 10 safety actions. Vicky's reviewed that evidence as the exec maternity safety champion and is happy that the evidence meets the standards required. So the next step is to complete a self-declaration form, which is signed by Joe, and that is submitted to NHS resolutions, and we should receive the rebate at some point. The last time it was around November. I can go through each safety action if you'd like me to. It depends how much detail you require.
No, I think if colleagues have got questions, now would be the right way into those. But just to echo the board's thanks, Emma, for all of the hard work and success around this. But let's see what we have. Jackie.
Thanks, Emma, and just to recognise the journey that we've been on for maternity. So well done. Just of the standards and the safety actions, are there any, in your view, that we need to do more on to be more robust, accepting that you're saying we're all compliant? Is there anywhere that we think we need to focus more on?
I think the area that we struggled with most and may not have met had they not reduced the requirements because of COVID was the multidisciplinary training, because the requirement is to have anaesthetists, theatre staff, neonatal staff, as well as all of the maternity service staff. So it's a large requirement on an awful lot of people. Previously the requirement was 90%. Even with COVID, we managed 84%. So we did, but because they then took away the 90% requirement for this year only, so we have met that standard. But I think that is the area that is most difficult to achieve. We have met it for the previous 2 years, but it's difficult to achieve that.
Yeah, so that would presumably be part of looking forward, how we can make it less difficult. Okay,
but Teams has made a real difference with that, though. We can do some of that training virtually, so that has helped and will help in years moving forward.
Okay, thank you, Emma.
Great, thanks. No more questions. Obviously a very good, clear paper. Oh, Vicky.
Not a question, Chair, but just to say, obviously, that although there is a significant amount of money attached to this, which is welcome, it's clearly about safety first and foremost. So I think it's a real credit to the teams that all of these things are in place, which ultimately are about keeping pregnant people and babies safer. So the paper probably just gives a bit of a headline, but the amount of work and the range of schemes that are involved are really very considerable, and certainly it's ensuring that we're providing a very good, safe service to pregnant people.
Thanks, Amanda.
Yeah, I can't echo my thanks enough to Emma and the team. They do a tremendous job under really, really tough circumstances. And whilst I'm not in a position to say yes to all the detail of the evidence, that's Vicky's role, I can actually say that this is a robust report, a really good return. And on the conversations that I've been having with other NED colleagues, we had a NED call during the week, all trusts are feeling exactly as Emma has described, that it has been more of a struggle to produce the evidence in COVID times, but we need to build this into our action plan going forward. And most importantly, we must make sure that we aren't reporting CNST, Ockenden, and all these various different avenues. We need a collective maternity strategy that embraces the totality. So when we come to our clinical strategy, it will be really good to have a section on maternity that continues this journey of growth, improvement, and most importantly, better experiences for our women and our staff. So I can't commend Emma and her team's work enough.
Thank you.
Thanks very much, Amanda. So I think formally we're asked to approve the submission. So I'm seeing lots of nods. So approved then. So thanks very much, Emma, and we'll see you a little later on, I think. So thanks very much for that. Steve, let's move on to the staff survey.
Thank you, Chair. I'm conscious that board members have, outside of this meeting, received a presentation by Quality Health, the providers of the survey, and therefore I'm going to take the paper as read, and I'm just going to bring out a few highlights. I think starting with the response rate, we maintained a response rate of around 51% this year against a comparator group response rate of 45.3%. Overall, our engagement score remained unchanged and is slap bang in line with the average in our comparator group at 7.03. I should say at this point that Quality Health, the survey providers, went out of their way to say that this was a very good set of results, that in the current climate and the current environment, where other trusts had actually seen a dip in their results, we have maintained and indeed in some areas improved our results, and that we should be very pleased with a good set of results. I'm pleased to say that 23 of the measures in the survey we sit in the top 20% in the country for. The survey is actually presented in themes and questions. There are 3 themes where we're significantly better than the sector or our comparator group, and those are equality, diversity and inclusion, immediate managers and team working. There are no themes where we're significantly worse than our comparator group. In terms of how we compare on a question basis, in terms of questions, there are 35 questions where we're significantly better than our comparator group. There are just 3 where we're significantly worse than the comparator group, and those are around MSK, musculoskeletal, which we've touched on already. But I come back to the point that whilst we treat this very seriously, actually our sickness rates around MSK are down on last year. The second area is bullying and harassment of colleagues, and the third is around being able to do the jobs to the standard that people are pleased with. So those are the 3 areas that you might expect are sitting behind our plans and priorities for the coming year. In terms of those plans, those plans and priorities are in 3 areas. Firstly, to demonstrate we care about staff members and their health and well-being, and this is going to be continue to work on mental health and MSK. We've touched on that already. And providing self-management tools and other tools that we're embedding into the organisation, and we've touched on that already. The second area is around reducing the incidence of harassment, bullying and abuse by colleagues. We're drilling down into the data to identify specific areas of concern. We're looking at how we can tackle those specific areas of concern, and we're developing a range of actions that will support a positive and inclusive culture, making clear that harassment and bullying and abuse are not acceptable in this organisation. The third area that we're focusing on is to continue to develop the trust as a best place to work. Now, what does that mean? My concern is that sort of a best place to work is sort of become 3 or 4 words rather than meaning something, and we're trying to bring some real meaning to it. One of the things we're doing is we're in the process of developing a partnership forum that will involve members of staff from across the organisation in providing their contributions to the decisions that impact them and the wider business decisions that we make. So that's moving from just working with our networks of protected characteristics and our staff side to actually creating a true partnership forum. Another thing we're doing is we're working with individuals to identify how we can improve job satisfaction. This includes, we talked about exit interviews earlier, this includes talking about stay interviews. It talks about asking people, well, what made you start thinking of looking for jobs elsewhere, and really trying to get to the bottom of what's frustrating people in their jobs and how we can actually make things better for them. And there are a number of other areas we're working on in that third area. But just to summarise, the 3 areas around health and well-being, bullying and harassment, and continuing to work on a better place. But in summary, I think overall, a good survey, but clearly always want to be better. Being average in the group isn't good enough for me. Being the top 20% in 2023 isn't enough for me. I want us to continue working across all of those areas. Thank you.
Great, thanks very much, Steve. Yeah, it was an interesting read. Miranda.
Thanks, Chair. It's a really impressive set of results, I think. So, you know, it's really a credit to the organisation. The bullying and harassment finding somehow sits at odds with the rest of the findings, which are really so good. And I wondered whether you had any information or you've got any reading back from the work you're doing on this to see how, A, is it widespread, B, is it confined to certain teens, and C, is it a function of the strange times we've been living in for the last year?
I think that's an interesting question, Miranda, and certainly in drilling down, you know, you do identify areas where there is more reports where you know, you think sort of culturally there's more that needs to be done, and we are identifying those areas, and we are actually putting interventions in around those areas. I think overall, bullying and harassment is something that I know all of the execs feel really passionate about, and you know, we do want to tackle, and we will tackle head on. I think through our Freedom to Speak Up Guardians and through other activities and our openness about this area, I do think we encourage people to speak up, we encourage people to recognise it, and we encourage people to call it. And in that sense, I do think people are willing to report it. So I think there's always this thing with results around a poor result can be a good thing because it means people are willing to speak up about it, but you need to be willing to take action around it. And I think that's the thing I really want to get to the bottom of is how bad is it in reality? Where is it in reality? And what are we going to do about it in reality? Focusing in on those on those particular areas where we have the issue. So I'm not sure I made that last point very well, and Joe put a hand up straight away, so maybe I'll hand over.
Joe.
Yeah, no, Steve, I think you did. I think there's no evidence in, I think, the data, the walking around. Steve and I meet with the Speak Up Guardians every month, although they've got direct access to us whenever they want to. I don't think we've got an institutional problem, and I don't, you know, but I do think there are pockets, as Steve says, and they're the ones we need to drill into. So I wouldn't want to leave the board with a view that we've got a significant issue, but you know, it is not acceptable in any case, and we need to tackle those specific areas where that has been identified. And there's also an element of people helping people with perception around what is being managed and what is bullying and harassment, and we need to do a piece of work around that as well. But fundamentally, we will tackle things. We do need, you know, to ensure we've got a zero tolerance on this, and therefore that's why it remains one of our top priorities. But I just wouldn't want people to leave thinking we've got an institutional problem, because I don't believe that we have.
Thanks, Joe. I think also the point about what is it to be managed and what is bullying and harassment is a very good point as well. Not to diminish the importance of the issue, but it's a point well made.
Thanks, Miranda. Any other questions on the staff survey for Steve? So, Steve, at some point, I guess you'll come back to us with more information about kind of action and initiatives as the response develops. Is that right?
That's right. That's right, Chair. There are actions in each of the divisions. There's actions at the top level. There's targets against those actions, and we will follow up with to the board. I'm through pod first on the outcomes of that.
Okay, if there are no other questions from Steve, thank you for that, and certainly well done to exec colleagues in getting such a good set of results. That's great. Item 12, verbal item, delegation of approval of the quality account. Vicky?
Thank you, Chair. Hopefully the board will be familiar with this. We've had a number of discussions at the Quality Committee and here at the board, and due to the ongoing pandemic, it was agreed that we would carry forward the three priorities about infection control, safety and perfecting discharge. So if the board are happy, we will continue and that will be monitored by the Quality Committee.
Great, I'm happy with that. If everybody else is, lots of nods, and that's agreed. Thanks, Vicky. Item 13, for noting the use of the trust seal, which information about which is there in front of you to note. And I think that then takes us to questions from members of the public. We've had one written submission from Mr. Campbell, one of our regular contributors, and as usual, he's asked a range of quite detailed questions that I know colleagues are going to respond to. He had one question that he specifically wanted us to raise today, and colleagues will correct me if I'm misrepresenting this, but the question is about our recovery plan, and in essence the question is why haven't we had a sort of full and detailed recovery plan paper to the board in the way that's gone to some other organisations. Now I think we've heard both from Tara and from Joe today about where we are in the cycle of that, but Joe or Tara, I don't know if you wanted to just deal with that specific point. Joe, perhaps?
Yeah, so I think specifically the actual final submission only went in last week. We do recognise that other organisations may have shared their draft plans. The plans that have been submitted that are being shared through the CCGs is a draft ICS plan, and therefore it's appropriate for them to share that. But we have reflected on that question and we'll make sure that we bring the plan forward for the next meeting. But I do think Tara has covered the updates on the as we have done at the previous meetings as well. So I probably haven't got any more, but thank you for the question, because we will reflect on that moving forwards.
Yeah, and I think it's a subject we've covered in quite a bit of detail today for sure. I know we've got a number of members of the public on the call, on the meeting call, can't call it a call, today. An opportunity to take any questions if there are any. If you could press the button and raise your hand if you have any. Liz.
Yes, please. I just was interested in maternity, and obviously, you know, sounds very good with the CNST. However, it doesn't portray that women do have a problem travelling over to Hastings, and it's not just Eastbourne women, it's from surrounding areas. And during COVID, with distance and travel being, well, advised not to travel, it has been particularly difficult, and probably the board are aware that there was a baby born in a car park in Eastbourne, and whether or not the new maternity strategy can actually look at the actual experience of women, but not in a sense, because they don't want to criticise the actual staff who are excellent, the service given in the place where they get their treatment is good, but it's actually outside of the hospital that is the problems that doesn't actually get recorded or mentioned anywhere. And I just wondered if that could be included somewhere, not obviously with CNST, but it is an issue, and particularly with COVID, it's been more of an issue. Thank you.
Thanks, Liz. Somebody want to pick that up? Joe or Vicky?
Shall I just come in, and then Vicky may want to come in as well. So thank you, Liz. And as always, you're representing you know, the beyond the hospitals and the hospital services as well. So I think as we are working through our clinical strategy, we will make sure I will take that on board and make sure we have reflected the people's experience beyond the immediate services as well. We'll make sure that's reflected in there, Liz.
Thank you.
Okay. If there are no other questions, I seem to have managed a 19-minute productivity gain by finishing a bit early. That being the case, I'll draw the meeting to a close. Our next public board meeting will be on Tuesday, the 10th of August. Thank you very much, everybody. For those who are involved in part 2, I'm going to suggest that we reconvene not at 1, but a bit earlier at 12:45. Does that sound okay, people? Lots of nods. Good. Thanks very much, everybody, for your contributions, and to those members of the public who came along to observe. Look forward to seeing you who are keen at our 10th of August meeting. Great. Thanks, everyone.